Good morning, everybody. I am so happy to be here for several reasons. One, this beautiful auditorium has been built by my senior, Dr. J.S. Rao, for such nice, good lectures and CMEs. He has been my senior in medical college. And I always wanted to give a talk from this podium in this beautiful auditorium. Secondly, the topic of clinical pearls was so interesting. I was excited actually. For many talks, it is sort of a very routine matter, but I was so excited. I thank Dr. Venkatraman for having selected this particular topic. So, respected chairpersons, Dr. Gopi and Dr. Chetan, and young pulmonologists and young intensivists who are aspiring to be in future a full-fledged faculty, ladies and gentlemen. So since Dr. Venkatraman has cautioned me that it has to be from the experience, whatever cases that I have seen in the last 43 years, select a few of them and then project it and put it across for a discussion. So I have about 6 pearls to share with you. So he said it would be clinical pearls in pulmonary critical care. Although I practiced clinical pulmonary medicine and did a few years of interventional pulmonary procedures, but my heart lies in critical care. That was because of my training in United States, where I went for a fellowship in critical care. So we'll start with the first clinical pearl, and that is, don't forget your physics. So here is a case. Young male, 26 years, comes with seizures. He was intubated in a nearby nursing home. He was shifted to a bigger institute and on ventilator for the last 4 days. Time came for weaning. Weaning parameters were met and TP's trial was given on pressure support. But something was wrong. Although his mentation was good, there were no seizures, patient was restless and anxious, tachycardic, tachypneic, and the tidal volume was low. So we were wondering what next. So there is when we suddenly remembered this equation. Anybody can recollect this equation? It states that the volume flow rate is directly proportional to the pressure gradient across the tube, and the radius raised to the 4th power. In simple terms, what it means is whether it is oil or liquid or air, it is much easier to pass through a bigger tube than a smaller tube because of the radius and because of the diameter ultimately. So the Poisson's law in more greater detail says resistance is the issue. Resistance is equal to 8 into viscosity into length of the tube by pi r4, and there is a radius. So what it means is, if the radius comes down by a fraction, by 1 factor, then the resistance goes up by 16 factors. So this plays such an important role in creating a resistance for the air to pass through from one end to the other. Since the patient was on a ventilator, it's the endotracheal tube, which is the point of discussion. The patient's endotracheal tube was 6 because it was done in a hurry in a smaller hospital with probably whosoever was present at that point of time. But then when the patient moved to a bigger hospital, we changed the endotracheal tube to 8.5, which was a desirable size actually for an adult like 26 years. And of course, what followed was not surprising. Patient was extubated the next day and he was discharged. So physics came to our rescue, but for that, we would have continued to ventilate and ventilate and ventilate. So we moved to the second case where the message is blood tests are important. So this is a 55-year-old grandmother brought to the emergency room with seizures, fever of 5 days, joint pains, headache, lot of constitutional symptoms, cough and breathlessness. She lives with her daughter and school-going grandchildren. The C-reactive protein was high, ESR was high, CBP was unremarkable. Chest X-ray showed bilateral shadows, 2D echo showed pericardial effusion, electrolytes were normal. So this is the X-ray. You can see the shadows in both the vases. And to get more information, a CT scan was done which also showed airspace consolidation. And short history, you can only think of infection in this lady. And the treatment, since she had a mild pericardial effusion, cardiac evaluation was done. Since everything pointed towards infection, antibiotics were started. And for cough and breathlessness, nebulization was done. And NIV was kept as a standby, mechanical ventilation kept as a standby. And the antibiotic selected at that point of time was piperacillin and tazobactam and vancomycin, which most consultants do in a situation like this. But then, day 4, no improvement. Patient's family asked, "What happened, doctor?" And the consultant says, "We have started the best antibiotics. We have to wait and see." But that was not the issue. There were a lot of missed or hidden clinical clues. This grandmother was living with 2 school-going grandchildren. That's an important point in the history. And did I say the complete blood picture was normal? We have to pay attention that the WBC is 6,000. Seizures, extrapulmonary manifestations, pericardial effusion, extrapulmonary manifestation, arthritis, again extrapulmonary, and lack of response to antibiotics. Just because we have selected piperacillin, tazobactam and vancomycin does not mean it's going to kill all the bacteria in this world. There are certain bacteria which do not get killed by these antibiotics. And what are they? They are Mycoplasma pneumonia, chlamydia and legionella. So they are all bunched together as atypical organisms which cause atypical pneumonia. In other words, they are also called walking pneumonia, but in some elderly people, it can mean hospitalization. Mycoplasma by far is the most common. Very tiny, very interesting organism. It is the smallest organism to be cultured. It's a free living organism. It has no cell wall. It's important to know because none of the penicillin groups can act on this because there is no cell wall. And it gets attached very easily to the mucosal surfaces. And that's the reason why it's very common in a situation where there are groups like school children in the classrooms. in colleges where there are about 40 to 50 people bunched up together, army camps. So if the person is coming from any of these situations, think of atypical organisms. These children bring the mycoplasma from the school and give it to their grandparents. And that's the reason why it's very important to know whether there are any school-going children in the family. And 20% of all community-acquired pneumonias are because of the atypical organisms. Keep that in mind because they need different approach. This is the commonest atypical bacteria. As I said before, extrapulmonary manifestations are very common. Nearly 1/3 of atypical pneumonias have extrapulmonary manifestations. So if a patient comes with a pneumonia, extrapulmonary manifestations, and there is some connection with the school children or coming from a college or army camps, think of these three organisms. And how does it look like in most situations? This is how it is. But just for your comfort, I'm also putting the CT scan of chlamydia pneumonia. And of course, what we have been seeing in the last 3 years during the COVID times, the COVID-19 pneumonia, where you see ground glassing uniformly, bilateral, extensive. So, how do we diagnose? Most of the times, lab diagnosis is not required. All that you need is a right history and empiric treatment and target the mycoplasma. There are investigations, of course, for those who want to make the patient spend money, PCR-based, molecular, IgM, but they are not yet validated. So this patient and the doctors realized that the high-sounding piperacillin tazobactam didn't work, vancomycin didn't work. What works in these patients is a macrolide like clarithromycin and doxycycline. In fact, British Thoracic Society says doxycycline is the best. Start with 200 milligrams, continue with 100 milligrams a day for the next week. These are the drugs of choice. And just out of curiosity, if this is 20% of all the community-acquired pneumonia, then what is more common? It is a pneumococcal pneumonia. So, a word about pneumococcal pneumonia. It's a dense consolidation on the X-ray, and you can see the air bronchogram in the CT scan. And if at all you do a sputum examination, because again, American Thoracic Society and ERS do not advocate a thorough investigation with sputum examination for community-acquired pneumonias, because 60 to 80% of the community-acquired pneumonias are pneumococcal pneumonias or streptococcal pneumonias. So no investigation is required, and classic presentation is fever with chills, WBC is skyrocketing, something like 16,000, 22,000, and not many extrapulmonary symptoms, and they respond very well to penicillin or penicillin derivatives. So our grandmother walked home happy, and she got discharged after 3 days. The third case is where we learn a lot about pressures. This is a patient who is 65 years, male, smoker, 40 packs years. 40 pack years means about 2 packets for 20 years. He quit 5 years ago, refined, we call them a refined smoker. And of course, he has been diagnosed as a chronic obstructive pulmonary disease. As the definition goes, FEV1 by FVC should be less than 70%, and quite a severe COPD because FEV1 was 40% of the predicted value, and He came to the hospital with increased cough, increased expectoration, increased breathlessness. So this is a classic acute exacerbation of COPD. And he had to seek emergency admission at night. When he arrived in the ER, he was drowsy but arousable. White cell count was high. Partial pressure of arterial oxygen was 60 millimeters of mercury. Partial pressure of arterial carbon dioxide was 70 millimeters of mercury. He was acidotic. pH was 7.25. Chest X-ray showed just COPD changes, no 2 Ps. There is no pneumothorax and no pneumonia. So this is what we look for in a patient who has a background of COPD when he comes to the hospital. The chest X-ray make sure that there is no pneumonia, no pneumothorax. We are happy. Electrolytes were normal, liver parameters, kidney parameters were normal. The 2D echo had shown a good left ventricle, but then the right side was all abnormal. The right atrium was enlarged, the right ventricle was enlarged. There was pulmonary arterial hypertension and right ventricular systolic pressure was high. So treatment was started, antibiotics. This is the recommendation given by GOLD guidelines that for acute exacerbation of COPD, go for amoxicillin and clavulanic acid. And just to cover the atypicals, add clarithromycin. Do not go for very high antibiotics like meropenem, etc. So antibiotics were started. Patient also was nebulized with a short-acting muscarinic agent, long-acting beta-2 agonist, inhaled corticosteroids. Patient was given diuretics because he had carpulmonale, and because he was hypoxic, oxygen was supplemented, and he was put on BiPAP. And all elderly patients, as soon as they arrive into the hospital, they should be given a shot of B1, B6 and B12, because these people are deprived of these water-soluble vitamins because of several reasons, and one shot of B1, B6, B12 should be given as the first injection, in addition to the low molecular weight heparin and fluids. So we were expecting a great improvement to happen. Whenever we put a patient on a BiPAP, the critical time to assess is 4 hours after. But 8 hours passed, there was no improvement. The partial pressure of arterial carbon dioxide stays where it was at 70. What went wrong? Was the mask not fit well? No, it was okay, because putting the mask and putting the straps too tight has its own sequelae. This patient probably has come out of NIV, but she is going to curse the consultant throughout her life. So what do? You use what is known as a 2 fingers rule. Insert 2 fingers, and over that you put the strap gently, softly. It should not be too tight. But then when you looked at the treatment chart, we quickly recognized that this was the culprit. Patient was on a BiPAP of 18/16. And we all know that the difference between the IPAP and the EPAP, that is inspiratory positive airway pressure and the expiratory positive airway pressure, here is just 2. And this is the pressure support. And we know for a fact that pressure support is the one which is driving the tidal volume. And tidal volume into the respiratory rate is the minute volume. And minute volume is the one which decides the carbon dioxide levels. So you need to use the proper pressure support so that you can drive away the carbon dioxide. Let us look if it is not 18/16 and if it is something else like 12/4, the pressure support would have been 8. And the general rule is EPAP should always be 1/3 of the IPAP. The new BiPAP machines has what is known as AVAPs, that is average volume pressure supports. They adjust themselves and then deliver the minute volume as you set. So you can use the formula P1 into V1 is equal to P2 into V2 to arrive at the minute volume that is desired to bring down the carbon dioxide levels. Non-invasive ventilation is an excellent intervention in critical care because we have done away with the endotracheal tube in many cases. We have been able to treat many patients, especially of acute exacerbation of COPD, without intubation and just with the NIV, because endotracheal tube has got a lot of complications and sequelae. So, but then NIV, does it have any proof that it works? Yes. It increases the alveolar ventilation, decreases the load on the respiratory muscles, decreases the chances for intubations, and decreases the intubation related complications, and brings down the ICU stay, brings down the ICU cost. There are two great papers, landmark papers on NIV. One was by Plant and his associates, where he looked at in a randomized clinical trial for 236 patients in 13 centers and proved that mortality can be brought down by 50% and endotracheal intubation can be brought down again by 50%. Much prior to that, way back in 1995, Brochard has shown that more or less the same results can be done. Now I said 18/16 is not right, 12/4 is good, but let us see what the NIV pundits say. All the people who have published papers on NIV. So if you look at all these authors who have published papers on NIV, the IPAP is double digit and the EPAP is single digit. And most authors did not really go beyond 15. So probably we should arrive at an average of 12/4 as the IPAP and the EPAP to get best results and extubate the patients. As I said, the new BiPAP machines has got average volume assured pressure supports. They're all called by different companies with different names. Some call it as intelligent volume assured pressure support. So if the tidal volume comes down, the pressure goes up, the pressure support goes up, and the tidal volume eventually also goes up. And the patient is maintaining good tidal volume, then the pressure support comes down. So there is an algorithm built into the machine where the machine senses the tidal volume for the previous 3 tidal volumes and then increases the pressure. Everything happens very fast. At the end of the minute, the patient would have achieved the minute volume, and in a matter of 2 to 4 hours, you would have achieved your desired partial pressure of arterial carbon dioxide levels. So just remember, pressure is volume and volume is carbon dioxide. So we'll move on to the 4th case, where it highlights the fact that devil is in details. A patient who is 67-year woman, diabetic, hypertensive, 60 kilos, known case of coronary artery disease, had PTCA 5 years ago, and this time she comes for a CABG, gets hospitalized, undergoes the CABG, and post-operatively, more than 48 hours passed post-operatively, and unable to wean or extubate. On pressure support, she was generating a tidal volume of 500 cc. There was persistent hypoxia. Hemodynamically stable, liver parameters, kidney parameters are normal, chest X-ray is normal. Bedside 2D echo showed good LV. Then what next? The preoperative reports, when we scanned through, it showed a hemoglobin of 16 grams, abnormal. RBC showed polycythemia, abnormal. 2D echo, yes, LV was normal, but that's not it. There is more to it. The pulmonary artery diameter was 32 millimeters and the pressures were 40 millimeters of mercury. Right ventricular systolic pressure was way high, much above the normal. So this was a case of chronic hypoxia. There was no pulmonary thromboembolism, there was no valvular heart disease, but this is a case of obstructive sleep apnea. And we know for sure that obstructive sleep apnea produces chronic intermittent hypoxia, which is responsible for the pulmonary hypertension. And these people have hypoxia all the time. And these people have pulmonary arterial hypertension. And that means we need to correct the obstructive sleep apnea to reduce the hypoxia and to reduce the pulmonary arterial pressures. So just for those who are not into pulmonary medicine, obstructive sleep apnea is where apnea is there is cessation of breathing for 10 seconds and more. Hypoapnea is where the flow through the nasopharynx is less than 50%. And clubbing the two, apnea and hypopnea index is created. If it is more than 5 per hour, it is obstructive sleep apnea. Although it is 5, most of my patients have got an apnea-hypopnea index of 20, 30, 40, 60, very high. So, and also there is a drop in the saturations. Surprising to see that some of the patients who undergo the sleep study, their oxygen saturations can drop as low as 40%. If a patient walks into the ER with 40% oxygen saturation, I'm sure the entire staff will jump on him and intubate him. But this is happening to the patient every night, day after day, week after week, month after month. And these people, that's how they develop chronic hypoxia. And this chronic intermittent hypoxia, one of the commonest causes is obstructive sleep apnea. And obstructive sleep apnea is not uncommon. It is almost 10 to 30% in the population. And what happens is there is an upper airway collapse at the nasopharynx and they develop intermittent nocturnal hypoxia. The mortality and morbidity is very high. If an ambulance brings an obstructive sleep apnea patient early morning at 4 o'clock with an acute MI, you can be 100% sure that acute MI was caused because of his severe obstructive sleep apnea. Same goes with a acute stroke, cerebral stroke. They are highly vulnerable for that. These people have daytime sleep and daytime fatigue and a lot of issues with their psychological parameters. So this lady was extubated next day and she was put on CPAP. She was discharged as per CABG protocol and she was advised to use a CPAP machine at home after discharge forever. So we move to the next case where it highlights the importance of accuracy, because accuracy is success. So this is a very short message. Those of you who are putting an internal jugular vein cannulation, now of course many people have started using the ultrasound to locate the internal jugular vein, but much before that it was by over a period of learning curve after puncturing the internal jugular vein several times. They were able to do that. So, or whether it is intercostal tube thoracostomy, the point where you put the needle first to inject xylocaine is very important. If the initial anatomical identification is right, then your procedure will be successful with less morbidity. So there is an old saying by the tailors, they follow a rule. They say measure twice but cut once. So my last pearl is how common sense is so valuable for us in medical profession, more so in the critical care, more so in pulmonary medicine. There was a recent publication in the American Journal of Medicine where there was a commentary on 5 common sense metrics, and later on another common sense metric was added, thereby it became 6 common sense metrics. So they are stopping the medications. Don't write in the case sheet, continue same treatment. Go through the list, stop the medicines which are not required. And most guidelines show that antibiotics are not needed beyond 5 days or beyond 8 days. And talking to the families is important. You may be doing a wonderful job inside the ICU, but it is important to talk to the family very softly, gently, answer all their questions. Talking to the other doctors, talk to the nephrologist, talk to the cardiologist, talk to all the other partners who are in the care of the patient. And wherever radiology is involved, go to the radiology department to discuss the issues with the radiologist, because there may be something that you will learn. And always use the evidence base. And last but not the least is examine the patient thoroughly. When you go to the patient, say, "Good morning, Reddy Garu." Don't look at the charts, don't look at the reports. You are not treating the reports like Dr. Rajshekhar Chakravarti mentioned or Dr. Rajshekhar mentioned. Don't treat the ECG. Examine the patient. You can look at the reports later. So, before closing, I leave you with a thought on the plate. Stop and think. Are we over-investigating? Are we over-treating? Are we missing hidden clues? So, my pearls, just to summarize: medical physics essential in critical care. Normal value also is diagnostic, just like we saw 6,000 WBC was atypical pneumonia. Pay attention to the guidelines. As I said in the NIV, look at the pressure support. Go back to old reports. Diagnosis is hidden in those old reports. Measure twice but cut once, especially for the procedures. And as I said, common sense metrics. So I close my talk by paying my tributes to one of the most celebrated, world-renowned clinician at par, Sir William Osler. He was working at Sir John's Hospital, Johns Hopkins, a Canadian by birth, but he is the one who brought medical teaching from the classrooms to the bedside. Thank you very much.